Welcome to the medication poster. We're going to talk about medications in older patients. Our older patients are much more likely to have medication adverse events than younger patients. And an adverse event is a medication reaction, or it could be a medication error, or it could just be an unusual response to a medication that we're not expecting. We do know that about 35% of our older adults have been reported to have an adverse drug event within a year's time, and those are community dwelling patients. We know for patients that are admitted to the hospital, for our older patients, about a quarter of them, or 25%, will have been admitted due to an adverse medication event. So we know these happen a lot. There are a couple of references that are available to help you decide which medications older patients are more likely to have problems with. One is the Beers criteria, and I do have a pocket guide for the Beers criteria that I will pass out to you. Another is the stop and start criteria. So we have some things that really contribute to why the older patients have adverse medication events. First of all, we know that as patients age, their body changes, and they don't handle medications quite the same way as they did when they were younger. We also know that there are certain groups of medications that are more likely to have problems for patients. And there are several things that happen for prescribing that can sometimes contribute to these adverse medication events. One is called the prescription cascade. Does anybody remember what the prescription cascade is?
I think it's when you prescribe a medication to treat the side effects of another medication.
That's right. Oftentimes, our older patients have side effects of their medication, and when they have the side effect from the medication, we might not recognize it as a side effect and add another medication. And this can go on, and pretty soon we have a very large medication list. So it's important to recognize side effects of medications. So to avoid the prescription cascade, treat each new symptom as a medication side effect until proven otherwise. And that is something that came from a physician that wrote a lot about polypharmacy, and his name is Dr. Gurwitz. We also know that medication non-adherence may contribute as well to our patients having adverse medication events. Patients don't take their medications correctly, then they're more likely to have an adverse medication event. And we need to assess for that. I use a mnemonic called COST-B, so I look at cost, organization, side effects, whether or not the patient has transportation to pick up their medications, and whether or not the patients feel that their medication is benefiting them. Medication transition errors are also an area where we definitely contribute to adverse medication events. Transition errors occur when patients transition from one place to another, and their medication list may not be quite as accurate as we would like that to be. So we're going to talk a little bit about the common medications that older patients have problems with. And one of the groups of drugs that older patients are most likely to have problems with are the benzodiazepines. They can increase the risk for falls. Many studies done on that show that they increase the risk for falls. We also know that they can cause a functional decline, probably contributes to why they increase the risk for falls. And we know that they have a higher risk of causing delirium. So if I tell you that we shouldn't be using benzodiazepines, I need to tell you in my next breath that we can't just stop them. This is a group of medications that it can be dangerous to just stop them without weaning them. So who knows how to wean a patient off of benzodiazepine?
I think I do.
Okay, good.
So we need to decrease the dose, but we need to do it by no more than 25% every 2 weeks.
Okay, you're right. No more than a 25% cut, no more often than every 2 weeks. We also have the non-benzodiazepine receptor agonist, and the most common medication in that class is the Zolpidem or Ambien. And those medications were really developed because we thought that they would have less side effects than the benzos, but that didn't actually work out. We actually do still have many of the same side effects, especially the falls. I wanted to also mention some examples of the benzodiazepines or medications like alprazolam, lorazepam, clonazepam, and diazepam. Have you seen any patients taking those types of medications? So important for us to try to limit the use wherever we can. Our next group of medications are called the highly anticholinergic medications, like diphenhydramine, a very common medication that's available without a prescription. Older patients often take it to help with sleep. It's one of the ingredients that's in Tylenol PM. for an example. Hydroxyzine is often prescribed for anxiety, but most of the literature that really studies how hydroxyzine works for anxiety did not include older patients. So we don't have much evidence on that it's actually safe in that group of patients. Dicyclamine, which is used for stomach problems, oxybutynin for urinary incontinence, promethazine and prochlorperazine for nausea, amitriptyline, cyclobenzaprine, and methocarbamol all can be used for either neuropathic pain or for muscle pain. So lots of medications in that class that are older meds but are still being used. We have problems with anticholinergics because they cause more side effects in older patients. Anticholinergics can cause some sedation. They also can cause older patients to become confused, to fall, urinary retention, and then constipation as well. And we think that the anticholinergic effects are worse in our older patients than they are younger patients because there is some documentation that as patients age, they have less cholinergic receptors. They start to lose their cholinergic receptors. So if you have less cholinergic receptors and you block what you have left, then therefore you do end up with having problems with these medications that are more so than the younger patients. I do want to point out that we have lots of alternatives to both the benzodiazepines and to the anticholinergics. So for the treatment of insomnia in older patients, which is what our non-benzo receptor agonists and our benzos usually are used for, what can we use other than meds for insomnia?
I would say that your sleep hygiene is important, so exercising throughout the day, limiting caffeine, and also having a bedtime routine.
Excellent. That's absolutely right. So certainly using sleep hygiene is better than using meds. We do know melatonin agonists may be a bit safer for our older patients, so those are another option. We know in our older patients they don't excrete as much melatonin and not at the right time. So we end up with having our older patients being a bit melatonin deficient. So giving a little dose of melatonin, I always do recommend that it's the USP rated brand so that we are sure that it contains what we think it contains. For anxiety, what else can we use for anxiety besides medications? Anybody?
You could do something simple like relaxation techniques.
Yes, that is excellent. Really, I usually recommend that our patients see a counselor. So I think a counselor can help to really get people in the habit of using these relaxation techniques and do some other things to help with anxiety. So we know that our guidelines do recommend our older patients do benefit from counseling as well. We also have SSRIs, SNRIs, and buspirone. For alternatives for our anticholinergics, we basically have several different things. Again, insomnia and anxiety, the same thing. For nausea, we could use ondansetron as long as the patient's QTC is okay. For muscle relaxants, we absolutely need a muscle relaxant. Tizanidine is one that's a bit safer. We do need to be a little bit careful with that with orthostasis, but using a low dose. For neuropathic pain, rather than using something like amitriptyline, we could use gabapentin, duloxetine is another choice, or perhaps topical lidocaine. And for allergies, rather than using diphenhydramine, using a medication like loratadine will have less of those anticholinergic side effects. In summary, we do know that older patients have lots of adverse drug events, much more common in older patients than in younger patients. So very important to be cognizant of the medications they're on and how that actually can contribute to a decrease in their function. We're now going to talk a little bit about medications and falls. Falls are very common in older patients. They occur in 1 out of 3 patients that are over the age of 65. So very common and very devastating event that can happen. And medications oftentimes are contributing. We have a whole group of medications that contribute to falls. We've already talked about the benzodiazepines, about the non-benzodiazepine receptor agonists, and the anticholinergics. All of those medications increase the risk for falls. I also have on the list the diuretics. So how do you think a diuretic increases the risk for falls in an older patient?
A patient taking a diuretic is going to go up to the bathroom throughout the night more often.
Right, so oftentimes they go more often and they also need to rush to the bathroom. So it is something to definitely, if they're on a diuretic and they have fallen, you want to ask if their fall was around rushing to the bathroom. So something to consider. We also have a group of medications that can increase the risk for orthostasis. Can anybody tell me what orthostasis is?
When a patient is lying or sitting and they get up, their blood pressure is going to drop.
Okay, very good. That is correct. So all blood pressure medications can cause orthostasis, but there's a group of them that are worse than others for causing orthostasis. So the ones that we want to stay away from in our patients that are at risk for falls are clonidine, the alpha blockers such as prazosin, terazosin, and doxazosin, and then short-acting nitrates, such as short-acting isosorbide is the most common one used. We also have our Parkinson's meds. Those are very high risk for orthostasis as well. So carbidopa, levodopa, or any of the dopamine agonists. And then tizanidine. As I mentioned earlier, tizanidine is a muscle relaxant we do use in older patients, but we have to use low doses and increase it slowly because it can cause orthostasis, which is unusual for a muscle relaxant. So I told you the medications that increase the risk for falls. What medication decreases the risk for falls?
Would that be vitamin D?
Very good. Vitamin D does have high-level evidence, meta-analysis of randomized controlled trials in patients that are deficient or insufficient in vitamin D that shows that it decreases the risk for falls. So in our patients that are falling, we do want to make sure that we assess vitamin D levels. We also want to assess calcium intake, but remember, we do have to, when we assess calcium intake, we have to ask about dietary calcium intake, because if we give too much calcium, that has been shown to increase the risk for heart attacks in our patients. So in conclusion, we know that medications are often a risk factor for falls. Our older patients are often falling, but that's not a normal part of aging. So very important that we review their medications and make sure that the patient does not have medication contributors to their falls. Thank you.
Thanks.